Good morning. This is Dr. Handwara. I'm here with Dr. Alex Manjarian. This is our next video on the series of depression. During the last video, we talked about neuroanatomy. We went through different areas of the brain that we are going to talk about today. So we are going to link everything together and talk about the neurobiology of depression. Now, as I mentioned, this particular field is pretty dynamic. So whatever you might hear today, it might change actually moving forward, but we will keep you updated as we move forward if there's any changes in the neurobiology of depression. So let's get started. A lot of these will be a revision that you already know from the previous videos. So one of the area of the brain that has been found to be hyperactive in patients with major depressive disorder is the lateral orbitofrontal cortex. Give me 1 minute. All right. So it's the lateral orbitofrontal cortex. The main function of the lateral orbitofrontal cortex is to process aversive stimuli, or we can refer to as punishment. So this particular area of the brain is hyperactive in patients with depression. Then we have the medial orbitofrontal cortex, which is responsible for processing reward or happy stuff, right? This particular area of the brain is hypoactive in patients with depression. And that makes total sense because in depression, the brain is more prone to process negative or aversive stimuli. Normally, the lateral orbitofrontal cortex will project to the dorsal anterior cingulate cortex. And the dorsal anterior cingulate cortex is a part of the salience network. And as we all know, the function of the salience network is to tag something that is important or give salience to a particular stimuli. The medial orbitofrontal cortex, on the other hand, in a healthy individual, will then forward the rewarding stimuli to the pregenial anterior cingulate cortex. And the pregenial anterior cingulate cortex will then send the information to the subgenial anterior cingulate cortex. This is a part of the anterior cingulate cortex just underneath the genu of the corpus callosum, right? Some literature also say this to be a part of the ventromedial prefrontal cortex. This then sends projections to different other areas of the brain, as we know from the previous lectures that it modulates the function of the amygdala, right? An area of the brain that is usually responsible for processing mostly aversive stimuli or negative information, but it can also process reward. The amygdala is usually responsible for giving salience to a particular stimuli. Salience basically means that whether this particular stimuli is important or it's not important, whether we need to pay attention to it or we do not need to pay attention to it or ignore it, as well as it also gives a valence to the stimuli. Valence is whether it's good or bad, right? And based on how the information is processed by the insula, the amygdala is then going to mount a physiological and a behavioral response to the anxiety or the threatening stimuli, right? The subgenial anterior cingulate cortex is also sends projections to the hypothalamus. And as we all know, hypothalamus plays an important role, especially in the controlling of the autonomic nervous system and the neuroendocrine response. It also sends projections to the insula. And as we all know, the insula plays an important role in interoceptive awareness. What that basically means is that is the conscious perception of the internal body states or the physiological state, right? So if the insula is hypoactive, you develop emotional numbness. If the insula is hyperactive, you usually develop hyperemotionality, right? That is a very simplified version of saying what the insula does. Insula also is responsible for increasing the intensity as well as increases the salience of a particular stimuli, the interoceptive as well as exteroceptive. For example, in PTSD, the insula shows increased activity. So there are two different types of PTSD. Okay, one classical type of PTSD shows increased activity. That means that it gives increased intensity, or it increases the intensity and the salience of a threatening stimuli. Okay, whereas in the dissociative type of PTSD, insula is hypoactive. We'll actually get to it when we talk about the PTSD, but I just wanted to give you guys what exactly is the function of the insula. The subgenual also sends projections to the periaqueductal gray. This is the area of the brain that is present in the midbrain. As the name suggests, aqueductal means it's around the cerebral aqueduct, the narrowest part of the ventricular system that connects the third ventricle to the fourth ventricle. The periaqueductal gray, its main function is, one of the main function is fight or flight response. It also has a variety of other functions. Plus, it also sends projections to the parabrachial nucleus, which is present in the pons around the superior cerebral peduncle. This particular area of the brain is usually responsible for integrating your visceral information with the thermal information, as well as the nociceptive signals, right? Because this is the area of the brain that gets information regarding various visual function from the nucleus tractus solitarius, right? So what I want you guys to remember is that the rewarding stimuli, whenever there is a reward, the orbitofrontal, the medial orbitofrontal cortex gets excited. It sends the projections to the pregenial anterior cingulate cortex, which sends it to the subgenial anterior cingulate cortex, which in turn projects into the hypothalamus, amygdala, insula, periaqueductal gray, parabranchial nucleus, as well as another area of the brain which is called as the nucleus accumbens, okay, which is basically the reward center of the brain, or also called as the ventral stratum. What happens now in depression? This is a healthy control. So in depression, what happens is that the medial orbitofrontal cortex is hypoactive, right? So the brain is not able to process a rewarding stimuli. On the other hand, there is an increased activation of the left orbitofrontal cortex, the area of the brain that serves a purpose in processing an aversive stimuli. So what they found is that in patients with depression, the left orbitofrontal cortex shows increased functional connectivity with the pregenial anterior cingulate cortex and the subgenial anterior cingulate cortex. So the area of the brain, the pregenial anterior cingulate cortex and the subgenial anterior cingulate cortex, which is responsible for processing rewarding stimuli, will now process aversive stimuli, right? Functional connection does not mean that there is a white matter connection between the two areas. It basically means that there is increase in the activity of these two areas, which usually influence each other. On the other hand, so let's stick to this. So once the aversive stimuli goes into the pregenial, subgenial anterior cingulate cortex, as we know, the subgenial in turn is connected to the hypothalamus, right? So one of the functions of the subgenial is to link a rewarding and an aversive or a punishing stimulus with the autonomic output. All right. And this is responsible for most of the neurovegetative and the autonomic symptoms that we see in patients with depression, right? Plus, it also actually sends projections to the insula, right, which is usually responsible for the emotional numbness that we usually see in patients with depression, right? On the other hand, in addition to this, the lateral orbitofrontal cortex also shows increased functional connection with other areas of the brain. And we talked about these areas. One of the area of the brain that it shows increased functional connection is the precuneus. We know exactly where this area of the brain is present. This is present on the medial part of your parietal lobe between the parieto-occipital sulcus and the cingulate sulcus. And this particular area of the brain is a part of our default mode network. And as we already know, the main function of the precuneus is the sense of self, right? Plays a very important role in autobiographical memory, as well as self-referential thinking. Now, what does that mean? Actually, there's an increased functional connection between the lateral orbitofrontal cortex and precuneus. That means that you will tag this sense of self or self-referential thinking with the negative emotional variance, right? You give it a negative value, and this is responsible for the low sense of self or low self-esteem that you see in patients with depression. The lateral orbitofrontal cortex also shows increased functional connection with the angular gyrus. And as we know from the previous videos, that the angular gyrus that sits on the top of the posterior part of the superior temporal sulcus, right? Its main function is processing language, or semantic processing. During depression, the increased functional connection between the lateral orbitofrontal cortex and the angular gyrus is responsible for tagging or linking the language with negative emotional variance. And this is responsible for the verbal or the linguistic expression of the negative self-esteem, okay, or the negative sense of self, right? So during depression, you'll see that patients with depression, everything that they talk about has a negative cognitive bias, right? Lateral orbitofrontal cortex also shows an increased functional connectivity to the visual cortex, right? And the part of the visual system that is called as the temporal cortex, right? So it shows an increased functional connectivity to the temporal cortex. And as we know, the ventral part or the most inferior part of the temporal lobe is responsible for processing visual information. So now the visual memory, all right, or the visual imagery will be linked to negative emotional variance, right? So it's usually like patients will now start ruminating over different things, about ruminating over negative visual images from the past, right? So they're not able to access that happy visual imagery. Or you can actually say that the visual attention is more focused towards negative visual imagery, right? Now let's repeat this. So in patients with depression, there's an increased activation of the lateral orbitofrontal cortex. There's an increase in the functional connection between the lateral orbitofrontal cortex to the precuneus, which is a part of the default mode network. And that's why the patients will ruminate or perseverate over negative self-esteem, right? They will perseverate, or there will be an increase in the verbal or linguistic expression of the low self-esteem because of the increased functional connection with the angular gyrus, which is also a part of the default mode network. There's an increased functional connection between the lateral orbitofrontal cortex and the temporal cortex, which is usually responsible for ruminating over negative visual memory or images. Apart from that, in patients with depression, there is also a decrease in the activation seen in the dorsolateral prefrontal cortex. One of the functions of the dorsolateral prefrontal cortex is the top-down control of emotion, that is cognitive control of emotion, or we can say it as cognitive reappraisal, which means that under stressful situation, our brain is able to develop coping strategies that can be used to decrease the emotional stress. That's cognitive reappraisal. So if the dorsolateral prefrontal cortex is hypofunctioning, we lose that top-down cognitive control over our emotions, right? Our emotions are no more cognitively controlled. The dorsolateral prefrontal cortex also plays a very important role in short-term memory. So the short-term memory will now be tagged with all these negative emotions, right? Another very important thing that they found in patients with depression is the decrease in the functional connection between the medial prefrontal cortex and the hippocampus. Now, this decreased functional connection between the medial orbitofrontal cortex and the hippocampus is responsible for the symptoms of anhedonia. That means that the patients are not able to extract the emotions attached to happy memories from the past. So they basically perseverate on the negative memories, things that they have lost, right? Now, one thing I want the audience to remember is that these patients don't have any problem recollecting happy or sad information. They don't have problem processing it, but they have problem accessing the affective value that is attached to these happy memories, all right? In one of the study, what they found is that in patients who are unmedicated, having major depressive disorder, the volume of the dentate gyrus, which has the stem cells and which are also responsible for something called as pattern separation, that is, if there are two things which are very similar to each other but is slightly different. For example, parking your car, we gave this example in a parking lot, but there are so many levels in the parking lot, and you park it, say, in the first level, and the next time you park on the fifth. It's the same parking lot, but it's two different spatial locations, right? So that is what the dentate gyrus does. It's able to actually do the pattern separation, so you remember where exactly you parked the car, right? So the volume of the dentate gyrus in patients with unmedicated depression is reduced by half in patients with depression who are unmedicated as compared to medicated patients or patients without depression. So what do we see in depression? In depression, we see an increased activation of the lateral orbitofrontal cortex. You see an increased functional connection between the lateral orbitofrontal cortex and the precuneus, the angular gyrus, the temporal cortex. You see decreased activation of the dorsolateral prefrontal cortex. Plus, you see a decreased activation of the medial orbitofrontal cortex and decrease in the functional connection between the medial orbitofrontal cortex and the hippocampus responsible for anhedonia. This is what we see in depression. Most of our antidepressants like SSRIs, SNRIs, TCAs, that is tricyclic antidepressants, are able to connect the problems in the lateral orbitofrontal cortex, right? So this basically the connection of the lateral orbitofrontal cortex with the precuneus, angular gyrus, and the temporal cortex, which are usually responsible for negative cognitive bias, is corrected by antidepressants, right? Like SSRI, SNI, RICE, and TCAs. But these same medications are not able to correct the functional problem between the medial orbitofrontal cortex and the hippocampus. That's why most of the patients with depression, even when they reach remission, anhedonia is something that lingers around, right? Memory issues are something that lingers around. And in one of the videos, we'll talk about why does this happen. There are a few hypotheses for this. And the only pharmacological intervention that is able to correct this problem between the medial orbitofrontal cortex and the hippocampus, this particular network problem, is ketamine, ECT, there's some literature on cognitive behavioral therapy, um, even fluvoxamine, which is available as a brand name called Luvox in the past. Fluvoxamine is one of the medication that we use very commonly in patients with obsessive compulsive disorder. It's able to address this anhedonia piece because of its effect on the sigma-1 receptors, right? So whenever patients with major depressive disorder, they have anhedonia, we usually have to use augmentation strategies, right? One of the augmentation strategies with atypical antipsychotics, which basically has a partial agonism at 5-HT1A receptors, like some of the medications we know is aripiprazole, brexpiprazole, cariprazine, right? Pramipixole is another medication, which is a partial agonist at D2 and D3 receptors, especially D3, that is also able to address the anhedonia piece. So one of the lectures we will talk about, or one of the videos we'll talk about, what is the hypothesis behind the inability of the conventional antidepressants to correct the anhedonia piece. Thank you very much for listening to this particular video. Have a nice day.